My name is Dr. Andrew Smith. I am one of the glaucoma specialists and cataract surgeons at the Gavin Herbert Eye Institute. I did medical school at Georgetown, and then I trained at UCI, did residency and fellowship here, and was lucky enough to stay on. And so I feel lucky to be here, and also lucky just to be in front of you all and giving a lecture. We're going to talk about the changes to the eye as you age and kind of the most common diseases or most common scenarios that people face, what to expect, and hopefully learn a little bit about that together. So let's get started. Okay, so I think in order to properly understand the age changes to the eye, we're going to have just a little bit of anatomy lesson so that we all understand how we look at the eye or how we view the eye. And so this is just a picture of the eye. You have the eye muscles on the outside. And what this arrow is representing is when we look at the eye, we typically like to cut it in half and then turn it to the side so we're looking on its side. So this is the motion of cutting the eye in half. And then this is kind of a schematic of it turned to the side so that we can look at it. So the front part, what we were looking at, that clear front parts of the cornea is, if you can see my mouse moving over here on the left side of your screen. And then the light passes through the cornea. The blue or brown part of our eye is called the iris. We have a lens here that's suspended in the eye. And then the back, the red is the retina, and the yellow here is the optic nerve that sends the signal to the brain. Okay, so this is another, so we're kind of on the schematic of the eye. So this schematic includes the eyelids, and then you have the cornea, and the light kind of passes through and gets to the back here. Another easy way to look at the eye is to divide it into the front and into the back. So the front includes things like your tear film, the conjunctiva, the cornea, which is that clear covering over the eye, the iris, the colored part of your eye, it's usually brown or blue, and the lens, which is suspended right behind the iris. And the back part of the eye is the things that you can see through the pupil and that are lining the back part of the globe. And so that includes things like the retina and the optic nerve. And we often take a photo of it that looks kind of like this, often red. And so the reason it's nice to divide the eye in that way is because the front part of the eye, its main job is to focus light into the back. So as the light rays come into the front part of the eye, every structure from the tear film, the cornea, the iris, the lens, its job is to try to get the light to focus into the back part of the eye. And that's in contrast to the back part of the eye's job, which is as the light comes into the eye, its job is to catch the light, create an electrical signal, and send that signal to the brain. And so the baseballs here kind of represent the light as they come into your eye. The retina's job is to be a baseball glove, catch that ball, and send the signal to the brain. Okay, so today we're going to talk about three things that are kind of more in the front part of the eye that are common with age or changes that happen with age, and three things that happen in the back part of the eye. So we're going to focus on these 6 areas to kind of understand aging in the eye. So the first, looking back at our schematic, is what happens to the eyelids as the eye changes, or as the eye ages. So there are a couple things. So the first thing is something we call dermatochalasis. So if you look at this person's eye, the eyelid here is drooping. So dermatochalasis is when you get excess skin over the eyelid, and that excess skin can push down on the eyelashes, and the eyelashes and the eyelid can start covering the vision. A similar phenomenon is called browtosis. And so that's where you have excess skin or sagging of the skin above the eyebrow, and things kind of sag down. So your eyebrow, which should kind of be on the bone as you push down on your eyebrow, can start to sag and again push down the skin over the eye, and you can't see as well. So this can block your vision. Often patients will come in and say they feel like they need to either raise their eyelids mechanically with their fingers, or they feel like they're constantly trying to open their eyebrows. They have a lot of wrinkles on their foreheads, and they even complain of headaches from constantly trying to lift their eyelids. Another eyelid change that you might encounter with age is something called ectropion or entropion. So this top picture is depicting ectropion. We have this cartilage in our eyelid that kind of keeps it against the eye. And as you age, those cartilage and its attachments can weaken, and the eyelid can kind of turn out. And so if you can see in this picture, the eyelashes are pointed down. And this is the inside part of the eyelid that's facing the outside world now. And again, that's called ectropion. The opposite can happen where instead of rotating out, as it weakens, it can rotate in. And as it rotates in, the eyelashes can start to hug the eyelid too tightly. And we call that phenomenon entropion. But both of these can happen just as the skin and the ligaments relax around the eyelid. And the reason it's important is because the eyelid, the bottom eyelid, one of its main function is to keep your tear film against your eye. And so if you don't have that eyelid structure, your eyelid can dry out and cause a lot of pain. And so some of the symptoms people will complain about besides just the look is that you get a lot of eye pain. You feel like your eye is extremely dry. That dryness can cause blurry vision. And if it's very severe, like these pictures are depicting, you could even get little cuts in your eye. We call them corneal abrasions, or even little thinning parts of your cornea. We call it corneal Dellen. So it can cause permanent changes to the cornea and to the eye. And so we want to fix these eyelid changes. So the first one is done, or all these eyelid changes are done by typically an oculoplastic surgeon. When the eyelid starts to sag, basically what you want to do is you want to tighten up everything. And the way you can do that is the first way you can do that is something called a blepharoplasty. So when the eyelid skin is sagging over the eye, you simply make a little incision over the eyelid. And you pull up the eyelid, and you can also even remove some of the fat while you're at it and try to recreate that normal curvature or normal sulcus of the eyelid. So you can go to the next slide. Another thing you can do with if the eyelid is sagging like that ectropion or entropion, what you do is you disinsert the ligaments that are attaching the eyelid to the eye, and you can shorten them and reattach it to the eye, and that will allow everything to hug back to the eye. And so the most common way we do that is something called a lateral tarsal strip, where they'll disinsert, shorten it a little bit, and then reinsert the eyelid so it can re-tighten up to the eye and apply those tears that you make onto the eye and prevent the dry eye and possible cuts. Okay, next slide. Okay, next we're going to move on to the cornea and what happens to the cornea as you age. So the most common things that happen with the cornea is it dries out. So in your tear film, you have three different components. You have water, mucus, and oil. And this picture at the bottom kind of depicts what that looks like. The water is typically in the center. The mucus kind of hugs the eye, and the oil floats on top of the water. And each of them are integral to maintaining a healthy tear film. And that healthy tear film helps to coat the cornea and keep it healthy, essentially. And so there are multiple glands that secrete the water, if you will. Most of us, the most common one that we talk about is called the lacrimal gland, but there's others called Krauss and Wolfring. Mucus is secreted by goblet cells, and oil is secreted mainly by meibomian glands. The mucus cells the goblet cells that produce the mucus are located throughout the conjunctiva, which is the front part of the eye. And then the oil meibomian glands are located right behind the eyelash. So if you look right at the eyelashes along the bottom part of this eyelid, there's a little margin there. And along that margin, there are about 30 different oil glands, and they secrete oil all day long. And that kind of lay on top of the water, and they basically prevent the water from evaporating. So when someone gets dry eye, and both are common with age, you have problems with the water, and you have problems more with the oil or mucus, and we differentiate between the two. And so that's what I'm going to do next. So go ahead and go to the next slide. The first one is what we call aqueous deficient dry eye, which is problems mostly with the water. So people will often complain of intermittently blurry vision, often when they wake up in the morning, or maybe when they're using their screens or reading a book or watching TV, it'll kind of become blurry, and then they either need to rest their eyes or blink it out, and it'll come back again. Other things are like tired eyes, or it feels like there's sand in your eyes. Some people actually get these quick little pains that shoot to the back of the eye, or even like a squeezing sensation around the eye. And then some patients even get sensitive to lights. Go to the next slide. In contrast to the water problem, there is something called evaporative dry eye, which is more of a problem with the oil. And so these are changes in the meibomian gland. So this picture up here on the right, that's a color picture of someone's eye, kind of shows what happens to the oil as you age. It doesn't come out, and a lot of people, it doesn't come out as a nice olive oil like it's supposed to. It kind of comes out, we say, like a toothpaste, or a little bit thicker. And so that thicker oil can't get out as well. So not as much oil is getting in the tear film. And not only that, it tends to come out very slowly and kind of solidify on the lid. And you get those, especially in the morning, wake up, little crusties on the eye. Those changes in, we call it mebum is the name of the oil, happen with age, and especially with things like menopause or hormonal changes. As your testosterone decreases, the mebum becomes a little bit thicker. In addition to that, in evaporative dry eye, the orifice becomes a little bit smaller. So this down here is really cool. So in clinic, you can actually take a picture of the meibomian glands. So that's what the black and white one is at the bottom. So the black and white one, these white little strands that are coming down the eyelid, this is the inside part of the eyelid, are the meibomian glands. And you can see right here in the middle that there is a lack of those white strips there. And so that's a lack of the meibomian glands and signifies disease. So this evaporative dry happens with age, but also happens with certain eyelid conditions, such as rosacea, which is a problem with the oil glands throughout your skin that can also affect the eye. There's some people think that the reason the meibomian glands decrease is a bacterial overgrowth. And there's even this little mite we call demodex that can grow on your eyelashes and affect the way the oils come out. Okay, you can go to the next slide. And so often, in contrast to water problems or aqueous deficient dry eye, evaporative dry eye, which again is a problem with the oil, it has some similarities and some differences. So the similarities is that you still get blurry vision that seems to be intermittent. But another thing that happens in evaporative dry, instead of feeling like there's sand in the eye necessarily, a lot of people will complain of tearing. So they're just either talking with a friend or watching TV, and all of a sudden they'll start to tear. And that makes sense that it's more an oil problem because you're making plenty of water is why you tear, but the oil is not able to get on front and keep the water on the eye. And so it just kind of runs down the eye. The eyelids and the eye even get itchy and a little painful. You get a little bit more redness, intermittent on and off redness. And then the end stage kind of is you get these big styes, or we call them chalazions. That is the top picture is trying to depict that little bump on your eyelid. Which is literally a clogged oil gland. Instead of the oil coming out where it's supposed to, right behind the eyelashes, it kind of bulges up like that and creates a little ball of inflammation. And we have to sometimes cut in those and drain them out. And then again, crust in the morning. Okay, you can go to the next slide. Aqueous deficient, like water, you want to replace the water. So you do things like artificial tears or ointments. You can put little plugs in the eye, and that kind of keeps the water around a little bit longer. Evaporative dry eye, you're trying to get those oil glands to fire a little bit more. And so the things we kind of run through are things like this. So you put hot compresses on the eye to try to open up those glands, and you're literally even trying to get the mebum, that oil, to be more liquidy. You can give yourself a little massage on the eyelid. There are these eyelid scrubs you can buy over the counter that you scrub your eyelashes, and you're trying to clean off the keratinization, we call it, or some of the debris over the eyelid orifices or the eyelid holes that secrete the mebum and open them up more. We can prescribe topical steroids to try to calm down the inflammation. There are some medications like doxycycline. The doxycycline happens to be an antibiotic, but it has the side effect of trying to open up some of the glands. It's also used in rosacea. You can use antibiotic ointments if you think it's a bacterial overgrowth issue. And then Demodex is this kind of there hasn't been a lot of treatment for it other than this we call tea tree oil, which is not listed here. But recently there was a medication that was approved called Lotilaner, or Xdemvy is the trade name. You take it twice a day for 6 weeks. So if you see evidence of these little mites on the eyelashes, you can try Xdemvy, and that's actually been pretty successful for the right people. Okay, you can go to the next slide. All right, moving on. So the next structure we're going to get to is the lens. So the lens is inside the eye, and in this picture you kind of see it pretty well. I often describe the lens as almost like a trampoline. So if you picture a circular trampoline, you have all the springs that are kind of keeping the trampoline afloat in the middle or above the ground, and that's the same thing as the lens. It's kept in the center of the eye, and it's surrounded 360 degrees by these little trampoline springs that we call zonules, and it sits in the eye, and its job is to focus the light. So go to the next slide here. So normally, the red lines represent the light as it comes into the eye and then hits that lens, which is the kind of green, pink circle thing in the center there. And the blue light is what the lens does. It helps focus it onto the back part of the eye. So go to the next slide. So it turns out that when you look at something up close, the light rays that go into the eye are not running parallel like they were in the previous slide. They kind of come out at an angle. And because of that, the lens has to work harder, it has to change its shape in order to keep the focus. So when you're young and you're in your 20s, you're able to kind of move objects from the distance all the way to up close, and your lens will change shape almost seamlessly and keep things in focus. Okay, go to the next slide. But as you age, your lens is unable to change. And so when you bring something up close, and so classically now it's been a phone, the lens is ability to change shape decreases so much that it can no longer focus on things up close. And we call that situation presbyopia, which simply refers to the lens not being able to change shape to keep something up close in focus. And so you can see as the red lights, or excuse me, the red lines come into the lens, that they're focused behind the eye. Okay, you can go to the next slide. And so the way you fix that is that you put glasses in front of the eye. Essentially, you're trying to put more power into your lens, and that's what glasses basically do. Go to the next slide. This condition, it typically starts around age 40, and it progresses all the way into your 60s and maybe even early 70s. And so during that time, the glasses become stronger and stronger for near. You feel like you have to pull out. That's the reason you hold things farther away so that it can relax your lens. You keep something in focus. Glasses work very well to help this problem, but it can be very frustrating for people. You can just get a simple reading glasses. You can get a bifocal. So that's just the reading glasses kind of tucked into the bottom part of the glasses there. And of course, you can get something called progressives, which is just a progressive lens. So it's a multiple different powered lens in a glass, and you're supposed to learn to use each power as things come close. Progressive lenses are fantastic. Some people love them, but some people have a very hard time getting used to them. And another thing you can do to correct the presbyopia, besides glasses, is cataract surgery is an opportunity to do that. So in cataract surgery, which we're going to talk about next, you're removing the lens of the eye, and you're putting an artificial lens in its place. And there are certain types of lenses that allow you to see far and up close. They don't work the same way. We don't have a true accommodative lens. And what that would mean is that the lens is actually changing shape, just like your natural lens does. But you do have this lens, if you can see it, I know it's kind of small, but it has these concentric circles in it. And those concentric circles give you multiple points of focus from far to up close, and it allows you to have some up close vision as well as far away vision. And so in essence, cataract surgery, if you get something called a multifocal IOL, which is what's being depicted here, you can correct some of the presbyopia. Okay, go to the next slide. And that transitions us to the next thing that happens as you age, and that's everyone gets a cataract. And so everyone will get some cataract changes. A cataract is different than presbyopia. So presbyopia is the inability for the lens to change its shape to keep focus. A cataract is when the lens starts hardening or turning colors and not letting as much light into the eye. And so here, this is a slide that depicts multiple different types of cataracts. Probably the easiest one to look at is the top right one, where you see the blue iris behind, the blue iris of the eye, and behind it, that white, almost brown in the center lens is the cataract. Often it's not that severe. It'll be a very severe cataract. And this white one, it's called a cortical cataract. Most people actually get the top left one. It's called a nuclear cataract, where the very center, the nucleus of the lens, starts to scar down and become yellow, and it's hard for light to get through. And then there's other types of cataracts, like the bottom one here on the left depicts a posterior subcapsular cataract. That's one that lines the back part of the eye. And then there's even fun kind of looking cataracts. This is more rare and associated with some diseases, but there's these ones we call them Christmas tree cataracts. This picture doesn't do it quite justice, but when you shine the light in there, you even get like some blues and greens that kind of shine out. It's kind of pretty. Okay, go to the next slide. And so this side now kind of depicts what a cataract does. So as the light hits that cataract, and you can kind of see it's a little bit hazy there, instead of being focused on the back part of the eye, the light goes everywhere. Okay, you can go to the next slide. Right. And we want it to do something like this. So this is what the lens would look like when you were in your 20s. Okay, go to the next slide. So one way you can fix a cataract is you can simply try to put glasses in front of the eye. Similar to presbyopia, you can basically offset the way the lens is not functioning well with glasses, and that works when the cataract's pretty mild. And then the next slide is going to have a video. Basically, the next thing you can do is do cataract surgery. And cataract surgery is, like we talked about, it's basically actually going in surgically, removing the lens from the eye and placing a clear lens in its place that will function similarly to your old lens. Now, the thing about cataract surgery that we should all know is that your lens, when you're 20 years old, that doesn't have a cataract in it, is far superior to the lenses, the implants that we have. And so you don't really get your vision back like you were 20 again. But when you have a cataract, often your vision is very blurry. You have a lot of glare, and that blare and glare is resolved, and you get really good vision with these lenses. Okay, next slide. All right, the next age change, we're moving back. That black circle is circling the space between the lens and the retina. And we call that space the vitreous space. And in that space, there's a jelly, and it's called the vitreous. And so that's what we're going to talk about next. So go to the next slide. So this jelly is in the eye. It helps when you're a baby, it helps your eye form a circle. But after that, it kind of just sits there. And as you age, it starts to shrink. You can kind of get these liquid pockets in it. So the gel becomes less viscous and more watery. And you see these liquid pockets as floaters. And so this picture underneath, that's a photograph, is depicting what we look at when we look at the eye. And you can almost see these like white wispy strands. And so that's the vitreous becoming a little bit less viscous, a little bit more watery. And what appears to people are these floaters. And often people say there's like little bugs floating around they want to hit, or it kind of pops out of them when they go either outside or they look at a white screen. And that's actually normal age changes. There is not currently a good treatment for it. Most of us say to watch it, and luckily the brain learns to adapt to it. So that's what we call neuroadaptation. And so most people say advise just to watch and wait. You can suck out the jelly via a procedure we call pars plana vitrectomy, but that's a pretty big, dangerous surgery. And for this, most often, we are not recommending that. Okay, you go to the next slide. So it also turns out that the vitreous attaches to the eye when you're a baby in order to help it form a circle, and attaches in a few different places like the optic nerve or the center of the retina or around the edges. And when you reach around age 65, so in your 60s, the jelly, because it's starting to liquefy, it will pop off the eye. And we call that phenomenon a posterior vitreous detachment. And it sounds scary, but it actually is a normal aging process and happens to everybody. And so this picture kind of tried to depict that. So this is kind of what the normal eye would look like filled with this jelly. And as you age, the jelly starts, if you look at the top right picture, you can see it's starting to separate away from the eye. We can examine that in clinic with our own eyes. We can also do a picture called an OCT. So that's what the very bottom picture is. The bottom picture is the same eye. So this is a right eye, and the left picture on the bottom is a black and white photo of the center of the retina. And the picture next to it, that's like has all those lines on it. That is the retina seen in cross section. And the very front part of that's kind of making like a curve, maybe V shape, if you will. That is the vitreous. And you can see it's attached to the retina at the very center and then coming off. And eventually that will pop off the retina. So when it's still attached, we call it vitreomacular adhesion, or VMA for short. And it's actually, I often document in our notes, but it's actually a normal a phenomenon. It's a normal change. We're just documenting that, hey, the vitreous is still attached for this patient. Go to the next slide. Okay, so the reason that we talk about posterior vitreous detachments is one, because they're symptomatic for patients. So most patients, the vitreous comes off the eye and they never notice. And we just one day look at it in clinic and say, oh, your vitreous came off. That's a normal process. You have a posterior vitreous detachment. That's normal. But occasionally it does cause symptoms. So either it causes a bunch of new floaters, or sometimes, or often a big floater right in the center of the vision. Or it causes flashes. And the reason it causes flashes is because the jelly is attached to the retina. And as it comes off the retina, it pulls on the retina, and it causes a little electrical signal to be sent through the optic nerve. And so it's almost kind of an illusion. It's really a pulling on the retina. It gives you these little, we call flashes, or some people describe a little lightning bolt, or a little, like someone's taking a picture behind your eye, and it just flashes at you. Um, if you have these symptoms of flashes or floaters, you need to come in and get checked. And the reason you come in to get checked is because if you have these symptoms, that means there's enough pressure on the retina to possibly cause a little hole in the retina. So 10 to 15% of people who have vitreous detachments that are symptomatic, meaning that they're noticing flashes and floaters, will also have a retinal hole. And so this picture at the bottom that's what that's depicting. You can see this white kind of opaque looking retina here is coming off the eye, and then right up in the corner where it says retinal tear is where a retinal tear, a retinal hole has happened. And the most common reason that happens is because the vitreous has come off, and as it's come off, it's a little too sticky and it brought a little bit of retina with it. And then after the hole is created, fluid can get into the hole and pull off the retina that's supposed to be attached to the back part of the eye. And then that's more of an emergency situation where we got to put the retina back on. Okay, go to the next slide. And so if you have a PVD or a posterior vitreous detachment that's symptomatic and you come in, one of the things you might detect is a hole. And so in order to treat that hole, what you do is you use a laser. So the top picture is a surgeon. He has a little, we call it an indirect ophthalmoscope, a little light on their head, and attached to that light is also a laser. And you can use this lens to actually look at the retina, find the hole, and then you use a laser to put these little burn marks around the hole that essentially tack down the retina around it so that the hole cannot cause a detachment. And so that's what the bottom picture shows. So after you get the laser, this is what it will look like. There, the very center of that circle on the left part of that picture is that you can see maybe just a little bit of it looks like a horseshoe tear, we call it. So it's a little tear in the retina. And then the burn marks are the circle that goes around it. So if fluid were to get under that hole and into the retina, it would not be able to extend to cause a detachment and worsen the vision. This is typically an in-office procedure. You go home the same day. There's not really a lot of precautions afterwards. Like you can shower and it's pretty much resume your normal activity. It does hurt a little bit, and you have to look often in a certain direction. So it can be sometimes challenging, but they're usually pretty successful, and they save your vision, which is really quite remarkable. Okay, go to the next slide. Okay, the next subject is something more dear to me. This is what I do for especially is glaucoma. So glaucoma is damage to the optic nerve. And so in this picture, the optic nerve is being circled. That's that yellow color that's in the very, very back. So we can go to the next slide. So it turns out that as you age, your optic nerves you have 1.7 million nerve fibers that come through your optic nerve, or about 1.2 and 1.7, and they can slowly die off. And that actually there's some normality to that, and it's not usually visually significant. But one of the major risk factors to glaucoma is also age, and that is an accelerated death to the optic nerve, and you start losing optic nerve fibers to the point where it becomes very visually significant. So that's one thing that should be assessed for patients on like an annual exam. So this picture depicts the optic nerve. So the very left picture is a very healthy optic nerve. You can see it has almost like an orange, maybe pinkish hue to it. It's very full and plump, we would even say. And then if you move to the picture in the center, this is like mild or moderate glaucoma. And what the optic nerve is doing here is something we call cupping. And so that means that white center, that yellow white color in the center is what we call the cup, and it extends out as you get glaucoma, and that is a representation to us that the optic nerve fibers that are coming through from the brain are starting to die off. And then the picture on the far right of your screen is very severe glaucoma, where you can see that white color is basically taken over the whole nerve, and there's very few to any optic nerve fibers left in this eye. And so that phenomenon is called cupping. Now, it does turn out, just while we're on this subject, that some people will cup naturally in their eye, or they're born with a little bit of cupping, and it's not actually disease or death of the nerve fiber of these fibers that are going through the optic nerve. And so that's one thing that we discuss and look at and have to differentiate between when you're looking at glaucoma and someone who naturally does this. Okay, go to the next slide. So what happens in glaucoma is typically you lose your peripheral vision first. And so the picture in the top right is the very end stage of glaucoma, where you actually stay pretty clear in the center, and people will even measure 20/20 in their vision, but they still will be technically legally blind. And that's because they're essentially black everywhere else, and they're looking through almost like a little straw or a little central island, we call it. And it can be very black like this in then stages. It can start blurry like that middle left picture, and you can get very kind of black spots out in the periphery. But to be honest, most people don't notice until the end. So all of these kind of where you would notice are more end stage. And so in order to detect glaucoma, we often do a peripheral vision test to see if our test can detect peripheral vision that's starting to deteriorate so that we can get on that and stop it. Okay, you go to the next slide. Over 2 million people in the United States have glaucoma, and half of these are undiagnosed. And the reason undiagnosed is the reason I just suggested, is that there's no symptoms until very late in the course of the disease. And so this is something that's important to get checked on an annual exam and make sure that everything looks okay. Okay, go to the next slide. The treatment of glaucoma is to lower the eye pressure. So often we think about glaucoma as having high eye pressure. It often does happen when the pressure is outside the normal range, which is 10, usually we say 10 to 21, but it can also happen in the normal range. And regardless of where you're starting, if we see optic nerve damage that's attributable to glaucoma, we will lower the pressure to try to slow down or hopefully stop the progression of glaucoma. Unfortunately, in the optic nerve and pretty much throughout your whole body, with some exceptions, once you lose nerve tissue, you can't really get it back. So the treatment has revolved around decreasing the eye pressure to stop the process, the accelerated loss of optic nerve tissue. You do that in three ways that are listed here. You can do it with eye drops that lower the eye pressure. We have 5 different kind of classes of medication that we typically use, and they basically work either by decreasing the amount of fluid that the eye produces inside the eye, or by increasing the amount of outflow. And a good analogy would be like a sink. So it's almost like they turn down the faucet of the sink, or they widen the sinkhole a little bit so more fluid can get out. There are a few laser treatments that work pretty well, depending on the type of glaucoma. So laser is often used to help get the pressure down. And then, of course, there's surgical interventions where we either give you kind of a new drainage system. Those are the first two, called a tube or trabeculectomy, or you do these little procedures we call MIGS, or minimally invasive glaucoma surgeries, that try to enhance your normal drainage system. But all of these, the drops, the surgical interventions, they all revolve around decreasing the eye pressure. But now we're kind of in the retina. And so this is a picture of the retina. All the red that you see is the retina. The retina is actually clear. It is not red. The redness comes from the choroid, which is in the back of it. It's all the blood supply. So your retina is actually a clear structure. But when you look in the back, it has the appearance of red a little bit. And so all that red is the retina. The very center of the retina, which is between these two kind of big arcing groups of blood vessels, is called the macula. And that's where our term macular degeneration comes from. And that's what we're going to talk about next. And it turns out what this is saying is the very center of the macula is called the fovea. And so that's why this word fovea is here. But we're talking about macular degeneration. We're talking about degeneration of the retina in this center area, which we call the macula. Okay, go to the next slide. So the full term for macular degeneration is actually age-related macular degeneration. And that's because as you age, this is what comes on. So working our way with all these pictures, the top left picture, in the center of the macula, around the macula, you have these white deposits. We call them drusen. They're protein and lipid deposits, and they deposit themselves in the retina, and they cause a lot of problems. They basically end up causing the death of the photoreceptors, which are the cells that actually capture the light and send the signal off through the optic nerve into the brain. Ultimately, they can do a couple things. One is they can cause a lot of atrophy. So now if you look at that center top picture, there's that huge white yellow spot in the center. And that is an area that's been denuded of retina. There's no retina there. And that's one of the end stages of macular degeneration. We call that geographic atrophy again. And the other thing it can do, now if you look at the top right picture, is it can cause these new blood vessels to form around these drusen, and those blood vessels will leak, and you can actually bleed into the retina, and that accelerates the vision loss. So in order to evaluate macular degeneration, we do look at the eye. So the top pictures would be what we would see on the exam. But there is this picture, which I've shown to you once before, but it's a technology called OCT that gives us a very good microscopic view of the retina. And what you want to look for, if you look at the bottom left picture, you get these little bumps on the bottom, and those are the drusen. So you can actually look at those drusen. And then if you look at the bottom right picture, you can find these fluid spaces. So that black fluid is actually fluid underneath the retina, and it's lifting it up. And that's the left picture is what we call dry macular degeneration, and the right is what we call wet. Okay, you can go to the next slide. And so the biggest misconception about dry versus wet macular degeneration is that they're two different diseases. They kind of are. They're more should be looked at as a continuum. Dry, most people start out as dry, and then as those drusen cause issues, they cause new blood vessels to develop, you can turn into wet. It doesn't necessarily mean that you absolutely will turn into wet if you have macular degeneration, but it really is a very similar disease process, just with kind of two different ways of getting there. And so basically the definition of dry age-related macular degeneration is no fluid on the retina. And the definition of wet is that there's fluid either underneath or in the retina. So yeah, so the wet is this fluid that's underneath the retina. You can go to the next slide, actually. So the vision is affected similarly. It's different than glaucoma, which has more peripheral vision loss. In age-related macular degeneration, you get more central vision loss. And so that top center picture with that geographic atrophy in the center, that's what would cause this phenomenon. So the left picture is normal, these two boys holding the ball, and then that kind of center vision that's blurry or been taken out usually happens when you lose a bunch of photoreceptors or a bunch of retina in the center. You can go to the next slide. Another thing that happens, especially with the fluid, is because the retina is being lifted up and it might be coming up and down, you can have these straight lines become wavy. So something that we give people with macular degeneration is a grid paper. So on the left would be a normal response. So this grid paper we give to you, all the lines look straight. You're supposed to look at this center dot and kind of evaluate the lines. But people with macular degeneration might have something that looks like on the right. They look at the center dot and they describe that in the section of the grid paper, it's either squiggly or indented or bowing out at them, or just anything that's not straight would be indicative of a retina that's not lying as flat and maybe has some undulations to it, and that is projected out into your vision. Okay, go to the next slide. And so the way we mitigate this is different between dry and wet. Dry macular degeneration, there's not a whole lot you can do. There's been one vitamin formulation that's been studied. We call it Eyelid 2, and there's a bunch of different companies that make it, but the formulation is called Eyelid 2. And it's basically a series of vitamins that are listed down here that are geared towards supplementing the retina to try to protect it from further damage from dry macular degeneration. And you take it twice a day. It seemed to slow things down or help about 35 to 40%. So it's not amazing, but it's just a vitamin. It's very low risk to take, and it seems like a slam dunk. So most of us will advise people to take that. We also tell people to wear sunglasses that are 100% UV protection. And then the other thing you do with dry is you usually see a year or every 6 months, and you shoot that OCT picture, and you're looking for it to see if it's going to turn into wet. Recently, it's not included on the side, so I apologize, but recently in dry macular degeneration, where there's a lot of geographic atrophy, there was an eye injection, a medication that you inject into the eye that's been approved to try to slow down the atrophy that happens. And so that's a relatively new treatment. Retina specialists are kind of in the middle, I think, of determining how they're going to use it, or if it's even appropriate to continue to use. But right now it's gaining a little bit of traction, and some people are using it, but it's in the middle of trying to figure out how it's going to work into clinic, is my understanding. Wet macular degeneration, you continue all the dry macular degeneration treatments, but there are all these intravitreal injections, which just means that you inject medication into the vitreous, or the back part of the eye, and they are designed to stop those blood vessels or that leaky fluid from happening. You're trying to dry up the retina. There's multiple that have been approved. They all work very well. But basically, what you do it in clinic, you put a little spring in the eye that keeps the eye open. You clean the eye, and then you go through the white part of the eye with a needle, and you simply inject the medication and come out. And they have been a total game changer in wet macular degeneration, where surgeons in the 90s would pretty much put their hands up and say it is what it is. These treatments have allowed people to keep their vision for a lot longer. But of course, at the price of putting a needle in the eye, and sometimes you have to you have to do the injection even every month for the rest of your life in order to keep the vision. And so if that's what has to be done, then that's what's done. And that's typically done again with the retina specialist. Okay, go to the next slide. In conclusion, if you work your way from the front to the back of the eye, pretty much every part of the eye tends to change with age and has some type of issue. The eye is a very complicated organ, and that's why there's so many specialists for one single eye. We all specialize. Typically, it's often anatomically oriented. We all either specialize in the eyelid, or we specialize in the cornea, or specialize in the optic nerve, or like glaucoma, or retina specialists. And that's because the eye is a very complicated organ. It's also a very beautiful organ, and it just takes a lot of work to take care of it sometimes. But ophthalmology is a very exciting field. All these things that we've talked about have continual updates and interesting things that are coming out to help with cataract surgery, or glaucoma, or macular degeneration. You can go to the next slide. And so that's why I'm just so grateful to be part of the faculty at the Gavin Herbert Eye Institute. This is not an up-to-date list, but this is most of us here. All the specialties are represented, and I just admire every single one of these specialists. So if you have a problem with your retina, say macular degeneration, we have amazing retina specialists. I think amazing glaucoma specialists, incredible cornea surgeons, and everybody on this photo here is just incredible. And so I just want to thank you again for your time tonight and the opportunity to talk with you.
Thank you so much, Dr. Smith, for this great presentation. Thank you so much and have a great evening.